So you have to note that nuts, corn, popcorn consumption. So if you see these in your board exam, oh, patient has, you suspect diverticulitis, which of these is a risk factor? And then you see nuts, you see corn, you see popcorn. They are not associated with an increased risk of of diverticulitis. That's why I said, do not be tricked. Do not be tricked. Nuts, corn, popcorn consumption are not associated with an increased risk of diverticulitis. So now let's move on to the management. With the management, we are going to look at it in various cases. So number one, if you have a patient with complicated diverticulitis, what approach will you take? When I say complicated diverticulitis, we've already talked about what makes diverticulitis complicated. Number one, perforation. Number two, intestinal obstruction. Number three, fistula formation. Can somebody remind me, how will a patient with fistula formation present to you in a board exam situation?
It will just
Diverticulitis.
having gas
Stool in
in
urine.
urine, stool in urine.
Gas in urine.
Beautiful.
And
Gas in the
dysuria.
urine, poop in the urine, dysuria. Okay, how will I be able to tell that this patient has obstruction, intestinal obstruction? What investigation will I do?
Direct X-ray.
CT with CT scan with
Abdominal X-ray.
abdominal.
X-ray
Supine
of
and
where?
direct
X-ray of the hand or what? Abdominal X-ray, right?
Abdominal X-ray.
And then perforation. How will I be able to detect perforation?
Air under the diaphragm.
Air.
Air under the diaphragm.
Yeah,
What about
under the
clinical
diaphragm.
evaluation? How will I be able to tell?
There will be hypotension.
Hypotension. So the patient will present
abdominal pain.
symptoms of diverticulitis with abdominal pain and shock, right? Or decreased blood pressure. This is beautiful. So if you have a patient with any of these, fistula, obstruction, or perforation, that patient must be managed surgically. So you want to call the surgeon. But before you want to do that, you want to check the patient's airway, breathing, and circulation. You want to keep the patient nothing by mouth, right? You want to start resuscitating the patient with fluids, because we said the patient may be in shock. And then you may want to give your antibiotics, and you want to pass your catheter because you want to monitor your urine output, right? And then you call your friendly neighborhood surgeon. That is it. Airway, breathing, and circulation, nothing by mouth, IV fluids and resuscitation, IV antibiotics. You pass your urinary catheter, you call your general surgeon ASAP. Hey, boss, please, I have this patient I need help with. Scenario 2. What about if you have a patient with diverticulitis with diverticular abscess? How we learned that there's a way you can be able to pick up diverticular abscess on physical exam. What one physical exam do you have to do? I've already shown you. Digital rectal exam. Good. So if you have a patient with diverticulitis, you make sure that you get your glove and then you do your digital rectal exam. And when you do your digital rectal exam, what will you be able to palpate on digital rectal exam?
A hard nodule.
Tender
Hard
mass.
Tender mass. Beautiful. So if the abscess is more than or equal to 4, and you can also do an ultrasound and even a CT. If the abscess is more than or equal to 4 centimeters, then you want to keep the patient on nothing by mouth or liquid diet. And then you may want to do an ultrasound guided drainage of the abscess. Then you give your IV antibiotics, IV fluids, IV analgesics. And if the symptoms do not improve, then you want to do a repeat CT in 2 to 3 days. And you also want to look, is it possible that this patient may have other complications, and you want to consult the surgeon as well, right? Diverticular abscess. And if you have a patient who has uncomplicated diverticulitis but needs admission, we are going to look into the criteria for admission. But first, uncomplicated diverticulitis but needs admission. How will you manage that patient? Keep the patient nothing by mouth or liquid fluid, liquid diet, IV antibiotics, IV fluids, IV analgesics, and assess the patient clinically every day. Uncomplicated, that means the patient does not have perforation, the patient does not have intestinal obstruction, the patient does not have fistula formation, right? nothing by mouth, IV antibiotics, IV fluids, IV analgesics, assess the patient clinically. If there is no improvement after 2 to 3 days, repeat the CT scan, look for new complications, and then continue treatment for 2 to 3 more days. If the symptoms do not improve, call a surgeon. Doctors, have you seen the stepwise approach? Stepwise approach. Everything stepwise. Beautiful. Okay. What about if the patient has uncomplicated diverticulitis and does not need hospital admission? Uncomplicated diverticulitis and does not need hospital admission. Uncomplicated diverticulitis and does not need hospital admission. So that patient, you want to do your outpatient pain management. So like oral pain management, okay? Whichever pain management will be helpful to the patient based on the patient's underlying medical conditions. Liquid diet, reassess the patient in the clinic in 1 week. And then advanced diet. So like as the patient is improving, you want to give the patient some advanced diet and reassess the patient again in the clinic in 1 week. So liquid diet, outpatient pain management, then reassess, and advanced diet, and then reassess, and then you do your colonoscopy 6 to 8 weeks later. Right? So the last but not the least. Yes, Dr. Cosmos.
Yeah, Dr. Bruni, please, what is advanced diet?
Oh no, the patient's regular diet.
Oh, okay.
Patient's regular diet. Yeah. Patient's regular diet. So how to decide on who to admit for inpatient treatment? And you realize that the criteria for admission, the patient must meet just one of them. So who needs to be admitted? Let's run through it. Can someone read this case for us, please?
Okay, I can.
42-year-old female presents to the emergency room with a history of left lower quadrant pain, which has been ongoing for the past 3 days. Temperature 38.2 degrees Celsius, BP 107 on 70, millimeter mercury, pulse is 78 beats per minute. You make a diagnosis of diverticulitis. Your colleague inquires about whether or not you will admit her. What factors will inform your decision about admission? List 5.
So why will I admit somebody?
Retype, fever.
Sure. I will admit somebody if the person has complicated diverticulitis, and that is perforation, obstruction, fistula formation. If the patient has sepsis, and what do I mean by that? Diverticulitis with temperature of 38 degrees or more, or temperature of less than 36 degrees, admission. Diverticulitis plus heart rate of more than 90 beats per minute, admission. Diverticulitis with respiratory rate of more than 20 cycles per minute, admission. Diverticulitis with leukocytosis or leukopenia, increased white cell count or decreased white cell count, admission. Diverticulitis with C-reactive protein of more than 15 milligram per deciliter, admission. Diverticulitis with severe abdominal pain, admission. Diverticulitis with diffuse peritonitis, which you'll be seeing on, whenever you tap any part of the abdomen, the patient is in pain, admission. Diverticulitis with failure to reduce abdominal pain in the emergency room, admission. Diverticulitis with microperforation, admission. Diverticulitis in a patient who is more than 70 years old, admission. If the patient even fulfills just one of them, admission. I'm not done yet. Diverticulitis with severe and significant comorbidities like diabetes with end organ involvement like retinopathy, angiopathy, and nephropathy, admission. Diverticulitis in a patient with myocardial infarction, admission. Diverticulitis in a patient with angina, admission. Diverticulitis in a patient with heart failure, admission. Diverticulitis in a patient with recent decompensated chronic liver disease, admission. Diverticulitis with renal end-stage kidney disease, admission. Diverticulitis on a patient with immunosuppression, like a patient who is taking long-term steroids, a patient who has been diagnosed with cancer and being managed, that admission. Diverticulitis plus a patient who is intolerant to oral intake, admission. In a patient who is unreliable to come back to the ER, or the patient who has lack of support system, or a patient who is non-compliant with care, admission. And if you also have a patient you manage on outpatient basis, but then the patient did not improve, admission.